Neurology quiz number 49. Describe the various disease-modifying therapies used in multiple sclerosis. Part 3 of 3. Discussion on infusible agents. Infusible agents. 1. Natalizumab or Tysabri. This is a monoclonal antibody first approved in 2004. Dose is 300 milligrams IV every 4 weeks. Initial trials showed that it reduced the annualized relapse rate by 67%. Mechanism of action: it binds to alpha integrins on the surface of B and T lymphocytes, blocking interaction with their receptors. This prevents the cells from binding to CNS endothelium, preventing trafficking of leukocytes across the blood-CNS barrier. It is indicated for RRMS, active SPMS, and CIS. Before starting natalizumab, tests ordered include liver function tests, a JC virus antibody index, and a brain MRI for comparison if new PML symptoms develop. During treatment, obtain JC virus antibody index every 6 months. Side effects: natalizumab is associated with increased risk of infections. It increases risk of developing meningoencephalitis from herpes simplex and varicella zoster viruses. It is associated with increased risk of PML and was initially removed from the market in 2005 for this reason, and then reintroduced as a part of a risk evaluation and mitigation strategies program in 2006. PML occurs almost exclusively in people with antibodies to JC virus. The risk of PML is established using 3 factors: time on natalizumab, prior immunosuppressive medication, and JC virus antibody index. Risk of PML can be reduced by increasing the interdose interval to 6 weeks. Rare but serious opportunistic infections include pneumocystis pneumonia, pulmonary atypical mycobacteria, and aspergillus infections. Another rare side effect is hepatotoxicity. Discontinuation of this agent can result in rebound MS activity, and it is recommended to start another DMT within 12 weeks after stopping natalizumab. It is recommended that women should not get pregnant while on this medication. However, the drug has not been shown to be teratogenic in animals, and data shows no increased risk of malformation or abortion in humans. If discontinued in anticipation of pregnancy, up to 40% of women experience intrapartum relapse with 10 to 20% risk of significant long-term disability. An alternative is to continue natalizumab throughout pregnancy, given every 6 to 8 weeks until the 32nd week of gestation. The drug is excreted in breast milk. Vaccination with live viruses is not recommended while on the agent. The drug can reduce immune response to inactivated vaccines. Number 2, alemtuzumab or Lemtrada. This is a humanized monoclonal antibody targeting CD52, which is expressed on lymphocytes, monocytes, and killer cells. It was approved in 2014. Dose is 12 milligrams q-day IV for 5 consecutive days. 1 year later, 12 milligrams q-day IV is given for 3 consecutive days. Prescribers must be certified with a risk evaluation and mitigation strategies program before using it. It reduces annualized relapse rate by 50 to 55%. Mechanism of action: it causes a rapid depletion of all types of lymphocytes. It is approved for RRMS patients who have failed 2 or more disease-modifying treatments. It is also approved for active SPMS. Tests ordered before starting alemtuzumab include CBC, LFT, BUN creatinine, VZV titer, urine analysis, and TB testing. Side effects: patients develop an infusion reaction characterized by fever, chills, arthralgias, and bronchospasm, which can be potentially life-threatening. Patients are pre-medicated with solimedrol 1 gram IV, diphenhydramine 50 milligrams IV, and Tylenol 500 milligrams. Patients are predisposed to infections. These include HSV-1 and 2, VZV, HPV, TB, Candida, and Listeria. Acyclovir 800 milligrams BID is given on starting treatment and should be continued for 2 months or until the CD4 count is 200 or higher. There is increased risk of autoimmune conditions such as Graves' disease and hypothyroidism, and this can affect up to 30% of patients. Other conditions include ITP, Goodpasture syndrome, and hemolytic anemia. CBC, kidney function tests, and UA should be monitored monthly, and thyroid function tests every 3 months until 48 months after the last dose. It can increase the risk of certain cancers including thyroid, melanoma, and lymphoma. papilloma. It should not be given during pregnancy. It can lead to inadequate response to vaccines, and it is recommended that vaccines be given 2 to 4 weeks before treatment or at least 6 months afterwards. Number 3, ocrelizumab or Ocrevus and ofatumumab or Kesimpta. Ocrelizumab is a humanized monoclonal antibody against CD20 which is found on B cells. It was approved in 2017. The first course is 2 doses of 300 milligrams IV given 2 weeks apart. Subsequent doses of 600 milligrams IV given every 6 months. It is approved for RRMS, active SPMS, CIS, and PPMS. It reduces annualized relapse rate by 46%. Mechanism of action: by its effect on B cells, it influences T cell activation and production of pro-inflammatory cytokines and chemokines. Tests ordered prior to treatment include hepatitis B virus screening and quantitative serum immunoglobulins. Side effects: these include infusion reactions, upper and lower respiratory tract infections, and herpes virus infections. PML is quite rare. The drug reduces IgM and IgG levels, and reduced IgG levels can be associated with serious infections. Monitor quantitative immunoglobulin levels during treatment, and consider stopping the drug if prolonged hypogammaglobulinemia or in presence of serious infections. There may be increased risk of malignancy, and in clinical trials, breast cancer occurred more frequently in treated patients. It is not recommended during pregnancy. Any required vaccination should be completed at least 4 weeks before initiation of treatment. Ofatumumab is another anti-CD20 cytolytic monoclonal antibody. The dose is 20 milligrams subcutaneously on weeks 0, 1, 2, and then Q4 weeks. It reduced annualized relapse rate in studies by more than 50%. It is approved for RRMS, active SPMS, and CIS. Side effects, precautions, etc. are similar to ocrelizumab.